All right, let's jump right into this explainer. We're tackling a topic that literally touches almost every single maternity ward across the globe, the 2022 AAP Clinical Practice Guidelines for Managing Neonatal Hyperbilirubinemia. Whether you're a seasoned pediatrician, a NICU nurse, or a med student doing your rounds, mastering these newly updated, absolutely life-saving protocols is non-negotiable for safe newborn care. Let's get into it. To really grasp why this matters so much, just look at the sheer scale we're dealing with here. We're talking about 60% of term newborns and a staggering 80% of preterm newborns developing visible jaundice in their first week. That's massive. It's actually the #1 cause of neonatal hospital readmissions. And because it is so incredibly common, it's dangerously easy to fall into the trap of thinking, oh, it's just routine jaundice, a harmless transition. But we absolutely have to stay vigilant. Because, well, the ultimate stakes of getting this wrong, they're absolutely devastating. Kernicterus is that nightmare outcome we are actively working to avoid altogether. Untreated, you're looking at a 1 in 44,000 risk of this. Unconjugated bilirubin crosses the blood-brain barrier and basically wreaks havoc, causing apoptosis and necrosis. The end result? A permanent, disabling neurologic condition. We're talking athetoid cerebral palsy, severe hearing loss, and upward gaze paresis. It is irreversible brain damage, guys, and it's exactly what we are here to prevent. So the key here is following a really structured roadmap. In this explainer, we're going to hit 6 precise steps. First, the threat of jaundice. Second, the 2022 AAP updates. Third, screening and risk assessment. Then, the phototherapy solution, followed by escalation and emergency care, and finally, safe discharge and follow-up. Okay, starting with Section 1, the threat of jaundice. We really have to begin by clearly separating normal newborn physiology from an outright medical red flag. Now, the clinical contrast here is super stark. Physiological jaundice usually pops up after 24 hours of life. It peaks around day 3 to 5 for term babies, the kid looks clinically well, and the total serum bilirubin stays safely below treatment thresholds. Pathological jaundice, on the other hand, shows up within those critical first 24 hours. So here's your golden rule. Jaundice in the first 24 hours of life is always pathological until proven otherwise. No exceptions. It points to a rapid, dangerous rise in bilirubin, often a hemolytic process, and it demands your immediate attention. Moving on to Section 2. The 2022 AAP updates. This was a monumental shift in how we approach this whole clinical puzzle. If you've been in practice for a while, you definitely remember the old 2004 universal threshold. Well, scratch that, because that one-size-fits-all approach is officially a thing of the past. The 2022 guidelines brought in precision curves. We are now using gestational age-specific thresholds. That means a 35-weeker has a completely different curve than a full 39-weeker, right? Plus, these are fine-tuned for specific neurotoxicity risk factors. And a huge change here, the APP now mandates universal pre-discharge screening using transcutaneous or total serum bilirubin for every single newborn between 24 and 48 hours of life. That brings us to Section 3, screening and risk assessment. Let's talk about the detective tools we use to gauge a newborn's risk before things spiral out of control. You absolutely must screen for these specific hyperbilirubinemia neurotoxicity risk factors. Why? Because if any of these are present, say being under 38 weeks gestation, having a serum albumin level dropping below 3.0, testing positive for isoimmune hemolytic disease or G6PD deficiency, or battling clinical instability like sepsis, it actively lowers the threshold for when we have to start treatment. Basically, these factors make the newborn's brain way more vulnerable to bilirubin toxicity at much lower concentrations. It's a game changer. All right, Section 4, the phototherapy solution. Once we spot the risk, this is our primary tool for intervention. When you need to rapidly drop those bilirubin levels, sticking the baby by a sunny window just won't cut it. And neither will those old standard overheads. We have to use intensive phototherapy. We're talking about a narrow-spectrum LED blue light, specifically tuned to about 475 nanometers. And it needs to pack a punch, delivering an irradiance of at least 30 microwatts per square centimeter per nanometer. You want to maximize the exposed skin, keeping that light about 10 to 15 centimeters away from the baby. The goal is to quickly convert that toxic, unconjugated bilirubin into water-soluble forms the baby can just excrete right out. But if those serum bilirubin levels are staying stubbornly high, we have to track the physical impact. We monitor for neurological damage using the BIND score. That's bilirubin-induced neurological dysfunction. We're looking really closely at 3 things: mental status, muscle tone, and cry. A score of 1 to 3 catches mild encephalopathy. Think of a sleepy baby with a slightly high-pitched cry. But guys, as those scores creep up to 4, 6, or higher, and you start seeing persistent retrocolitis or a shrill, completely inconsolable cry, we are entering the very dangerous territory of moderate to severe encephalopathy. Which leads us right into Section 5, escalation and emergency care. If phototherapy isn't doing the job, our whole narrative shifts instantly from routine care to high-stakes intervention. The absolute crucial takeaway from the AAP here is exactly this quote: escalation of care is a medical emergency. Do not wait. Seriously, do not delay. You have to treat this with the exact same urgency as a code blue, because that window to prevent permanent brain damage, it is closing rapidly. When that emergency actually hits, you've got to execute these 4 stat steps without hesitation. Number 1, bypass the ED completely for a direct NICU admission. Number 2, start emergent intensive phototherapy and IV hydration. Do it during transport if you have to. Number 3, send your stat labs immediately. And number 4, get on the phone with the blood bank and prep your team for an urgent exchange transfusion. And you may be wondering, exactly when do we pull this alarm? It's not a guessing game. The absolute trigger for this escalation happens the very second the total serum bilirubin hits exactly 2 milligrams per deciliter below the exchange transfusion threshold. The moment you see that number, you initiate the emergency steps we just talked about. Boom, right away. Now, during this emergency, these specific stat labs are 100% non-negotiable. You need total and direct reacting bilirubin, a full CBC, serum chemistries, and to prep for that transfusion, a type and cross-match. But notice something here. Serum albumin is also explicitly required. We desperately need that to calculate the bilirubin to albumin ratio. That ratio is what tells us the amount of free, unbound bilirubin floating around, which is exactly what poses the highest toxic threat to the baby's brain. So when do we actually pull the trigger on an urgent exchange transfusion? This is a massive procedure that replaces about 85% of the infant's red blood cells, and it must be done if the baby hits any of these 3 critical criteria. First, if they show any signs of intermediate or advanced acute bilirubin encephalopathy, like arching or an altered cry, regardless of what their bilirubin number is. Second, if they actually hit that exact TSB exchange threshold. Or third, if that bilirubin to albumin ratio we just talked about exceeds their specific gestational age limit. Finally, Section 6. Safe discharge and follow-up. Assuming the baby is stabilized or never even needed escalation, we move to the final supercritical phase, getting them safely home. A safe discharge relies completely on a rock-solid structured follow-up. You absolutely must adhere to this discharge timeline. The general rule of thumb is pretty straightforward. The earlier a baby leaves the hospital, the sooner they have to be physically reevaluated. If they're discharged before 24 hours of life, you need to see them again within 24 hours. Discharge between 24 and 48 hours, follow up within 48. This strict timeline is exactly how we catch any delayed bilirubin peaks before they can spiral into a crisis. We also really have to watch out for rebound hyperbilirubinemia. For high-risk infants, especially those who are DAT positive, meaning there's active hemolysis, or babies who had to start phototherapy before they were even 48 hours old, you can't just turn off the blue lights and wave goodbye. No way. They require a mandatory TSB recheck within 6 to 12 hours after stopping phototherapy, just to make sure we don't miss a dangerous rebound spike. So, as we wrap up this explainer, I really want you to ask yourself, how does mastering these incredibly precise guidelines change your approach to the first delicate days of a newborn's life? Because applying this rigorous, evidence-based structure is exactly what allows us to safely balance vigilant, life-saving clinical care with giving new families the peace of mind and those vital bonding moments they so deeply deserve. Thanks for exploring